Welcome to the Cold Steel Surgical Podcast with your hosts Amir Farouk and Chad Ball. We've had the absolute privilege of chatting with some amazing Canadian as well as international guests over the past year. While the topics have been broad in range, whether clinical, social, or political, our aims for the podcast continue to remain the same. We hope to inspire discussion, creativity, scholarly research, and career development in all Canadian surgeons. We hope you enjoy our second season as we continue to highlight some incredible guests, deliver detailed masterclass sessions on a myriad of clinical topics, and introduce some fresh new features such as debate and companion formats. We hope you relish the podcast as much as we do.
It is astonishing how a pea-sized gland in one's neck could be so troublesome. Dr. Jesse Pasternak is an endocrine surgeon at Toronto General Hospital. In this episode, we delve into the workup of hyperparathyroidism, Dr. Pasternak's approach to parathyroid surgery, as well as his thoughts on the introduction of new surgical techniques.
Well, welcome, Dr. Pasternak, to Cold Steel. Thank you so much for carving out time in your super busy schedule. All the amazing things that you do, we really, truly, and deeply appreciate having you on. I was wondering if you could just briefly describe for a few listeners who maybe don't know you as well as we do yet, where you grew up, what that was like, and then what's your surgical and medical training pathway look like?
So first of all, I want to thank you both for having me on. It's really, I didn't know much about the podcast until relatively recently, and then when I found out about it, I started listening to it, and I thought this was like, what is needed in Canadian, even international surgery. A lot of my mentors have been on it, and it's just an honor to kind of join them in this podcast. So I really appreciate you having me on. First of all. Second thing, so in terms of my kind of journey through medicine, I grew up, in the suburbs of Toronto, and my parents, neither of them were physicians. Neither of them actually went to university, and my older brother was my first experience with somebody who went to university, and he ended up being a personal trainer and lives in LA now. And myself, I decided to kind of pursue the medical route because I really wanted to, work with people and help people. When my family had some experience with the diabetes, so I wanted to be an endocrinologist actually when I first went into medical school. And I went through my my undergraduate degree. I went to McGill for anatomy and cell biology, and I also took a substantial course load in humanities, including religion and economics and international relations and all sorts of hodgepodge of stuff. And then I ended up going to McMaster for medical school. When I was there, I kind of really was keen on being an endocrinologist. So I spent a lot of time with endocrinologists. I spent, I'd go to I'd try to do research in endocrinology. I spent time doing genetics of diabetes work. And then that kind of led me to deciding whether I wanted to be an endocrinologist, which would be internal medicine. And then I kind of had a couple experiences in surgery, and that led me to an elective actually I took at UBC with the general surgery people out there. And I met a chief resident at the time named Adrian Melk, who many of you may know, who's now an endocrine surgeon in Vancouver. And she actually told me that, you sound like you're really interested in endocrinology. I said, yeah, and I really wanted to be an endocrinologist, but I kind of really, got souped up by the surgical side. And she said, there's something called endocrine surgery, and I'm doing a fellowship in that coming up. And I said, oh my gosh, that's insane. So I started looking into it a little bit more, and I found out that there's actually something called endocrine surgery across Canada, and there are giants in endocrine surgery across Canada, including even at the University of Calgary. Janice Pasica is one of my mentors and is a giant, and you've had her on your show, and she's really a force in surgery, but also specifically in international endocrine surgery. if you mention her name in any circles around the entire world, not only have they heard of her, but they know her very well. So I didn't know that this existed across Canada until I did that elective. And once I did that, I started doing my research. And when I started my general surgery residency, I started getting into the research and the kind of the real clinical side of endocrine surgery, and then did a fellowship in San Francisco with Orlo Clark, who essentially started him and Norm Thompson, who Dr. Pasika did her fellowship with in Michigan. Them two started the endocrine surgery kind of specialty in the mid 20th century, and so that Dr. Clark and Quan Du, who was also a big name and who still is also a big name in surgery, was one of the first people to popularize the laparoscopic adrenalectomy, and kind of being exposed to some of these giants in endocrine surgery made me think this is something that we can actually expand even further across Canada, and kind of coming back and being recruited back to Toronto was really an awesome opportunity to start an academic career in endocrine surgery, and that's kind of where I am now.
I wanted to ask you about your work around decision making for low risk thyroid nodules. I love the stuff that you've worked on in terms of like trying to figure out what the best treatment options might be for patients faced with this situation. We of course interviewed Dr. Urbach about a study that he did in looking at that I think you were also involved with, looking at the language that you use around thyroid nodules and how that impacts patient decision making. What about this topic interests you so much?
This topic is something that we could talk about for hours, and I think the reason is because the jury is still out on the way that thyroid cancer, because people evaluate thyroid nodules for the risk of thyroid cancer. The general public, when they think of cancer, they think of something that's, you need to treat aggressively. You need to make sure that, you don't leave any cells behind. You have to make sure that if you have a second or multimodal therapeutic option, you use those things. And I think that idea of treatment of cancer really is not applicable to most majority of thyroid cancers. And so I think I realized that, going through general surgery residency, we were exposed to so many different types of cancers and so many different types of aggressive cancers in general surgery. In thyroid cancer, it's a much different story. And I think the issue stems from, even up until about 10 or 15 years ago, there was many different physicians. One notable one is a guy named Dr. Mazaferi, who published multiple papers saying basically we need to stamp out thyroid cancer when we find it. We need to treat it with total thyroidectomy. We need to treat it with radioactive iodine. We need to treat it with thyroid suppression. I call it the 333. In fact, the evidence does not show that when you look at it. When you look at the large studies that we have now. And one specific example of this, and I always say this in my talks, is that we have a study that looked at 50,000 patients in a large American database, and it showed that if you did a total thyroidectomy on them versus a lobectomy on them, or taking out half the thyroid, you actually had a worse outcome if you did a lobectomy. And then another group led by Julianne Sosa, who is now the chair of surgery at UCSF and a big force in endocrine surgery. She's an endocrine surgeon and a surgical oncologist. She actually reviewed, and she's also an epidemiologist. She reviewed those data a few years later, most of the similar data with a epidemiologic endocrine surgical bent to it. And she found the exact opposite result. And in fact, lobectomy and total thyroidectomy have the exact same outcome. And so I think the idea behind treating thyroid cancer is, and that applies to thyroid nodules, is really based on the fact that we need to kind of move away from the previous thoughts of how to treat thyroid cancer in the context of treating other cancers. And specifically regarding thyroid nodules, we worry about thyroid nodules so much because of the risk of thyroid cancer, because we think we need to treat thyroid cancer aggressively. And if you think about thyroid nodules and the detection of thyroid nodules, if I did a thyroid ultrasound on every single person walking down the streets of downtown Toronto or anywhere in the world, I'd have about a 50% likelihood of finding a thyroid nodule in you. And so if we treated every thyroid nodule aggressively and we worried people about thyroid nodule, we would have no ability to treat anybody else in our health system. And we'd also create a quality of life of everybody that had a thyroid nodule, which is quite concerning. People would be worried about this all the time. So I think the ideas behind what thyroid nodules are, what thyroid cancers are, really needs to shift. And it's not necessarily about the evidence, because we have a lot of evidence. It's about changing the attitudes towards what is a thyroid nodule and what is a thyroid cancer. And I think those are slowly changing. One example of this, and I'll just briefly say this example, is that we're starting active surveillance trials in Toronto up to 2 centimeter thyroid cancers that are diagnosed as thyroid cancers. We don't actually operate on them, and the treatment is to monitor them. And this is based on large data sets from Japan showing that decades of monitoring small thyroid cancers produces patients that don't need surgery. In fact, less than 5% of those patients actually have any sign of metastatic disease. And if they do have metastatic disease, you can just treat those with the usual surgical management, and they do fine. So we up to 2 centimeters we monitor, and initially when we started this trial, people were like gasped, like, how could you do something like this? And then over the course of the last couple of years, we have slowly started to change the hearts and minds of the referring docs and the other stakeholders in the thyroidology world, and in the region, at least where I work, it's mostly accepted. You should see like the kind of hate mail that I would get from publishing some of this stuff. CMAJ, I published a paper about de-escalation of thyroid cancer care, which I got hate mail. I give talks at the endocrinology societies, and I get hate mail about that. And people would like stand up in the podium and on the podium and say, how could you advocate for this? And I think as long as we use the evidence, and as long as we can, at least get the people who are treating these patients on board with the evidence, we'll be able to treat the cancer adequately. One of the thyroid surgeons at Memorial Sloan Kettering, Ashok Shah, used to say, the punishment must fit the crime. And so we shouldn't be doing such big treatment modalities for thyroid cancer when it's not actually going to hurt you or kill you throughout your life.
It's such a remarkable time to be a surgeon. Like, there's so much evolution in so many different fields, from thyroid cancer to breast cancer to rectal cancer. Like, it really is just a remarkable time to be a surgeon. Like, it's fascinating. I think it is only fitting that we use your expertise to talk a little bit about parathyroids, and I'll just plug you again that you gave a great talk for us. So every year the graduating chief residents in Canada go to Toronto for a review course prior to our Royal College exam, which is the equivalent to the board exams in the U.S. And you gave a great talk for us on thyroid cancer. So I'm hoping to leverage your expertise again today on the podcast to kind of give us a crash course on parathyroid disease. So let's just talk a little bit about some basic calcium phosphate PTH metabolism. For the junior resident, can you break down a little bit about how does calcium phosphate get handled in the body, and where does PTH fit into that?
So I think if you're gonna be writing any of your exams on in general surgery, or even if you have any parathyroid issues, things you got to learn about, I think the best thing to kind of start from is from the beginning, and the fact is that the history of parathyroid disease has been longstanding, and obviously as many of you know, the first parathyroidectomy was done in the 19th century, and it was done by a guy named on a guy named Charles Martel, who was a captain in the Navy in the U.S. And he had parathyroid disease, and there's some nice pictures in the literature of him before he was stricken with the parathyroid disease, and then after. And in fact, he underwent multiple parathyroid surgeries by multiple surgeons at large reputable centers in the U.S. And he had, and they knew that his calcium was high because he had the end-stage calcium issues. And we always talk about, the medical students always talk about like bones, groans, moans, psychiatric overtones. But I think that the key parts to parathyroid disease when we're treating it today, because we don't really view those manifestations anymore. The main things we talk about is high calcium causing kidney stones and causing osteoporosis. And those are the two main symptoms of parathyroid disease. From a biochemical standpoint, calcium has since the 1970s we've had a very high throughput, easy to measure calcium. There's a calcium test that was developed in the 70s, and since then there's been widespread use of calcium. So calcium is actually the first thing to be seen to be elevated, and it's often seen in an asymptomatic patient, especially in North America. So calcium, when your calcium is elevated, I think that's when you have to try to think about what's happening with this patient. And as many of you know, the most common reason for an outpatient to have elevated calcium is primary hyperparathyroidism. Now, the phosphate is something I could talk about for a long time, but I think that the take-home points about phosphate is that in secondary disease, it's much more important, and those are patients with kidney disease. In primary disease, it is often low, and that's related to the kidneys as well. And Dr. Pasik always says, it's a poor person's PTH. You see a low phosphate and high calcium, the patient has primary hyperparathyroidism. That's sometimes the case. Sometimes you don't actually have very low phosphate. But I think, nowadays, as long as your calcium is elevated and the PTH is also elevated, that is a clear diagnosis of primary hyperparathyroidism. Unless we talk about vitamin D. And I think vitamin D is actually more important to talk about in the diagnosis of primary hyperparathyroidism than phosphate. So I think the key diagnosis of primary hyperparathyroidism is calcium being high or high normal, the PTH being high or high normal, and the vitamin D being normal. Because as you know, vitamin D is highly deficient in our population, specifically in Canada. And so vitamin D that's very low can actually cause the PTH to be high. And so if you have a relatively normal or high or a relatively normal calcium or high normal calcium, but your PTH is very, very, very high, then it could be related to vitamin D. And if you give vitamin D supplementation, the PTH and calcium stay normal. So I think vitamin D, calcium, and PTH are the most important biochemical factors to diagnose primary hyperparathyroidism.
So let's say you're seeing a patient who's been referred to you because they have a high calcium and high PTH. How do you approach that patient from a history and physical perspective?
So the main things about parathyroid disease is that you have to understand, you have to have a good approach to these patients in a very stepwise fashion. And I think that's where the problem lies in the surgical and medical community, is that we jump steps. And I think that if you review a parathyroid patient from a stepwise fashion, you'll really get it every single time. So there's three questions that I usually ask, and this came from Dr. Kwan Du, who's one of my mentors in San Francisco, and he said the first question you need to ask is, do they have the disease? And so you review the calcium, you review the PTH, you review the vitamin D. If those things line up, then you have primary hyperparathyroidism. The second question, then if they don't have that question, you can't move to the second question. And that's a key point. A lot of people move to the second and third questions, which I'll tell you about in a second, without actually making the diagnosis of primary hyperparathyroidism. And unless you make that diagnosis, you can't move on. So let's say we've made that diagnosis. The second question is, should they have an operation? And having an operation depends on two factors. The first is if they have symptoms. And the symptoms that we know about these days are as I mentioned, kidney stones and osteoporosis. So if the patient has kidney stones or any ultrasound findings of kidney stones, even asymptomatic kidney stones, or if they have osteoporosis done by DEXA scan, which is a bone mineral density scan, then they deserve an operation. The people that don't meet those two criteria still can get an operation if they meet the asymptomatic guideline criteria. And there's a host of criteria, and those revolve, I won't kind of go through them, but they revolve around whether the patient's young, whether the patient has very, very high levels of calcium, or whether the patient has any renal disease. And so if you think about the long-term complications of parathyroid disease, it makes sense, right? You don't want somebody that has already starting renal disease to have even worse renal disease. And renal disease happens because of high calcium over long periods of time. You don't want them to have very, very high levels of calcium, because then they can have inpatient stays related to the elevated calcium. And we can talk about, and you probably have reviewed, if anyone that's studied for any exam, reviewed how to manage elevated calcium. And one of them, many of them require inpatient stays. So you don't want to have very high levels of calcium, which is also dangerous to the end organs as well. And you don't want somebody that's very young, because the younger they are, the longer they'll live with the parathyroid disease. So I think the asymptomatic patients as well as the symptomatic patients deserve an operation. Now, the issue I said before, you can't move on to the next step without having checkbox. That question applies a lot here as well. People move on without actually having a clear understanding of whether the patient needs an operation. So if you do check this box and say the patient needs the operation, then you can move on to the third question. The third question is how to do the operation. And this is where all the scans come in. So you could see that the first and second question have no connection to scans. Yet a lot of patients are referred without fully being worked up and already have scans in place. And sometimes they're not referred because the scans are negative. Again, not following the 3 steps in sequential order. Okay, so the first step is, do they have the disease? Second step is, should they have the operation? And the third step is how to do the operation. And how to do the operation is variable depending on what kind of, across the world, depending on what kind of resources available you have. In my practice, I do 2 imaging studies to localize disease. And those imaging studies that I do personally are my own ultrasound. So I do a surgeon perform ultrasound, and I do ultrasound on every thyroid and parathyroid patient that I see in my clinic. And I localize the disease, especially parathyroid disease, relatively easily. And then I do usually a functional scan, like a sestamibi scan. I've also done a bunch of studies on other types of functional imaging, like PET-MRs using fluorocholine and those types of things. But I think from my perspective, the easiest scan to get is a sestamibi scan, which is actually quite a poor scan, but it's the best functional scan we have available in my region. So that's what we use. Some people use CT scans, which is not technically a functional scan, but CT scan, they call it a 4D CT scan, that's often used, but I don't personally use that in my practice on a regular basis. And so once I localize, or if I can localize a lesion, then I'll do a minimally invasive focused parathyroidectomy. And minimally invasive parathyroidectomy is a very fluid word. A lot of different people use it for many different reasons. And I won't go into that specifically, but what I will say is that it's not okay to localize a lesion, take someone to the operating room, take that lesion out and close them up and send them home. Because in my opinion, if you do that, not my opinion, but in the data, if you do that, you have between a 5 and 10 up to 15% chance of persistence/recurrence rate. And that's too high for me. So what I do is I do an intraoperative PTH value where I check the levels of PTH while the patient's sleeping. And if the PTH levels go down adequately, and we have algorithms to decide if it's adequate, then the patient's cured, and the recurrence/persistent rate is probably around 1% or less. If the levels don't go down, that's when you convert to the 4-gland exploration. And I can do a 4-gland exploration fairly quickly, and I would just look at all the 4 glands, make sure they're all, look at which ones are big, which ones are small. And usually, if the PTH hasn't gone down, they have multiple adenomas or hyperplasia. And that's a long conversation as well as what is hyperplasia, what is multiple adenomas. But I think a 4-gland exploration is necessary if your PTH doesn't go down. Now, if you don't have PTH available in your center, you can still do parathyroid surgery for sure. But I think in that situation, it's really incumbent to understand what your recurrence/persistent rates are going to be if you only do a single gland excision or a unilateral excision where you look at two lesions on that side, or a 4-gland exploration where you look at all 4 glands. And I think that needs to be discussed with the referring docs, with the patient, and understand your rates yourself of what your persistent recurrence rates are.
I think where people get really confused sometimes is even at that first stage, like you talked about, right? Making the diagnosis of whether they have the disease. Can you just explain for our listeners what's the difference between primary, secondary, and tertiary hyperparathyroidism, and how do you differentiate those things on laboratory examinations?
Okay, I'll make it. It's basically a 2 second discussion. Primary disease are patients that have elevated calcium in the setting of elevated PTH, or high normal calcium in the setting of elevated PTH, or elevated calcium in the setting of high normal PTH with normal vitamin D. Those are all forms of primary hyperparathyroidism. None of those patients have renal disease causing their parathyroid disease. So primary hyperparathyroidism is when the parathyroids themselves independently are causing the problem. So that's fairly easy, and you can recognize that fairly easily because the patient's either not on dialysis or has never had a renal transplant. So if the patient is on dialysis or has a renal transplant, then those patients are either secondary or tertiary. So that's a really easy way to kind of diagnose it. I'll go even further and say a patient that's on dialysis, that's not had renal transplant, has secondary hyperparathyroidism. And almost every patient that's on dialysis will have secondary hyperparathyroidism. The rates are, 75 to 80% have substantial secondary hyperparathyroidism on long-standing dialysis. So I think secondary disease, dialysis, and then once patients get a transplant, after the some people have different ways of classifying them, but from my perspective, once a patient has a transplant, that's when they can have tertiary disease, and tertiary disease usually comes with elevated calcium. On the other hand, we think about patients with secondary disease that are on dialysis, they always have low calcium because the vitamin D levels are low. They're not able to, simplistically, they're not able to absorb calcium. And so the calcium level's low, and therefore the PTH levels go high to try to normalize that calcium. So it's a pretty simplistic thing. Primary disease, when the parathyroids cause it themselves. Secondary disease, when you have long-standing dialysis and you have stimulation of a parathyroid disease because you have low calcium. And tertiary disease, when you have a kidney transplant and long-standing secondary disease from being on dialysis. Now you have a kidney transplant, and those parathyroid glands have been working so hard for so long, they can't go back to normal, and they become autonomous and start making elevated calcium.
Yeah, I think that's a very easy and not hard way to think about those three things, and that I wish someone had told me that 5 years ago. But I just wanted to go back once again just to the diagnosis perspective. Like if you ever want to kill an afternoon, and you could start looking up the differential diagnosis for hypercalcemia on Up to Date. How do you differentiate? They always talk about these familial syndromes like hypocalciuric, hypercalcemic, all those kinds of things. Like, what are there any other investigations? Like, let's say you have someone who has looks like they have primary hyperparathyroidism. How do you distinguish between or rule out those things that might mislead you?
So the one test that we usually order for in primary disease, and you talk about familial hypocalciuria when the urine calcium is very low, hypercalcemia and the blood calcium is high. That's a familial disease affecting the CASA receptor, which is in the kidney, and that's the calcium sensing receptor. And in that disease, the body actually pulls the calcium in from the kidney. And so the urine calcium is low. Now that disease is not treatable with surgery, and so the way to rule that out is to make sure that the urine calcium is not very low. And so that's one kind of test, an adjunct test that we do. It's very, very rare to have that problem. And so some parathyroid surgeons' usual practice to do it for every patient. Some parathyroid surgeons is not, and they basically just take that risk. But that's one way to kind of rule out familial hypocalciuria, hypercalcemia. The other genetic syndromes are still primary hyperparathyroidism, like MEN2, MEN1. These are still primary disease because the gland is itself the primary aspect of the disease itself. The gland is causing the problem. So the other diseases are all still a form of primary hyperparathyroidism. But when you talk about familial disease, you talk about a higher propensity, in my opinion, to multi-gland disease. And that's what I see a lot, because I do a lot of parathyroid surgery. I see many of the patients that have a family history. So if you take a family history of parathyroid disease when you speak to patients, then they tell you, oh, my mom had parathyroid disease, or my sister had parathyroid disease. That sets off kind of the alarm bells in your mind to say, oh, this may be a familial disease. And as long as their sister or their mom didn't have a pheochromocytoma, you can probably be sure that it's not MEN2, it's probably MEN1. And MEN1 disease is actually somewhat quite common in some areas, even in Canada and in some areas in the US. And MEN1 disease is associated with multi-gland disease. So that's why when I see somebody that has mild hyperparathyroidism, in the sense of low levels of calcium, they're still elevated or high normal, but low levels of calcium, if they're young, if they have family history, then that sets off alarm bells for multi-gland disease and or MEN1. And those are patients that I would do further testing, either genetic testing for MEN1 or other associated syndrome testing, like pituitary workup and stuff like that. As you remember, MEN1, pituitary disease, parathyroid disease, and pancreas disease. The 3 Ps.
The 3 Ps. When do you start worrying about things like parathyroid carcinoma preoperatively? Is there anything that will kind of tip you off preoperatively that would start you down that pathway?
Yeah, so a lot of people will say if their calcium is really high, their PTH is really high, then they have a suspicion of parathyroid carcinoma. In fact, if your calcium is very, very high and your parathyroid hormone is very, very high, you still likely don't have parathyroid carcinoma. Some of my senior colleagues, Lauren Rothstein's my senior partner. He's been doing this for decades. He's probably had less than a handful of parathyroid carcinomas in his entire career. So parathyroid carcinoma, and he's a subspecialty parathyroid surgeon. So parathyroid carcinoma is very, very uncommon. And it's something that we sometimes recognize intraoperatively. We see that the parathyroid lesion is almost invading, or there seems to be, a very fibrotic reaction around the parathyroid lesion. And I think that those are the more telltale signs. Ultimately, the parathyroid carcinoma is very, very uncommon. And I'm doing some studies now to look at some of the genetics of it. So if we can actually predict it, because even now, we have parafibromin staining, which sometimes helps us decide if it's parathyroid carcinoma. But even now, it's still somewhat ambiguous whether the parathyroid carcinoma is in fact a parathyroid carcinoma, or if it's an atypical parathyroid neoplasm. And so these are kind of a continuum of atypical parathyroid disease. That from the get-go. But I think if you have a very elevated PTH and a very elevated calcium, those are kind of set you off to be concerned. But I think it's still very likely that those patients still have benign disease.
All right. So I think it's time to kind of get us close to the operating room here. But before we dive into how you kind of approach the parathyroid operation, can you talk a little bit about the anatomy of the parathyroid glands? Because obviously I think that's the key in terms of doing a good parathyroid surgery. Tell us a little bit about the anatomy of the parathyroid gland and sort of the landmarks that you're looking for and thinking about when doing the operation.
Yeah, so that's something that I get asked a lot, actually. And I think, when I was even a medical student resident, I was kind of trying to understand the parathyroid glands in the context of the schematic diagrams on the textbooks. And it's really hard to kind of understand them because they're very small. They're almost impossible to see. I remember being in the operating room many times with my mentors, and they're like, "Oh, here's the parathyroid." I'm like, "Yeah, that looks like it." And I had no idea what they were looking at. Zero idea. So that's a completely normal experience to have. For any of the residents that are listening, that's a completely normal experience to have. It's like a slightly different tan color than the fat around it. Again, you almost will never see it unless you see a lot of them. And that's what makes a parathyroid surgeon a parathyroid surgeon. Just as an aside, one of my mentors, Ted Young at McMaster, who actually has since retired, he said the best localizing study for parathyroid disease is to localize a good parathyroid surgeon. So I think that really tells the idea that it's very hard to recognize parathyroids unless you have a good understanding of the anatomy and where you're going to find them, and you almost don't even need to see them, you just know where they're going to be. So in terms of where the anatomy side of parathyroids are, I think the key really is to be able to understand the thyroid and understand where in relationship to the thyroid you're going to find the parathyroids. In addition, you have to know where the recurrent laryngeal nerve is running, and that also helps find the parathyroids. And then obviously the vessels of the neck, so the carotid artery is what I use as a landmark as well for the first of the parathyroid. So two things I'll say. The first is that parathyroid glands, people call them upper and lower, or superior and inferior. But in fact, the anatomical landmark for parathyroid glands comes from the development of parathyroid tissue, which is in the fetal development. And they come from the third and fourth branchial clefts. And the fourth branchial cleft and the third branchial cleft actually flip as they're descending down into the place where they're going to be in the lower neck. And the fourth branchial cleft travels with the superior parathyroid gland, and the third branchial cleft travels with the inferior parathyroid gland and the thymus. And so when they come down into the neck, the superior parathyroid gland from the fourth, or the inferior parathyroid gland from the third branchial cleft actually flips and goes in front of the third, and goes and basically forms the thyrothymic ligament and the thymus. And so that's where you're going to find the inferior parathyroid gland, just in the inferior aspect of the thyroid and in the top of the thymus. The superior parathyroid gland flips, as I said, behind the third branchial cleft. So the fourth branchial cleft, which is containing the upper gland, flips behind the third branchial cleft and forms the superior parathyroid gland in the posterior aspect of the neck. So to make a long story short, the superior parathyroid gland is actually the posterior parathyroid gland, and the inferior parathyroid gland is actually the anterior parathyroid gland. And that's the best, in my opinion, that's the best way to find these parathyroid glands. And so if you're looking at the thyroid, you're looking at the recurrent laryngeal nerve, and you look behind, posterior to the recurrent nerve, posterior to the thyroid gland, you're going to find the superior parathyroid gland. And if you look anterior to the nerve in the thyrothymic ligament, you're usually going to find the inferior parathyroid gland. And that's how I kind of decide at least where to start looking.
Can you walk us through a little bit about how you approach this operation? Let's say if you were going to do a classic 4-gland exploration.
So I think maybe you're talking about like technology and stuff that I use in the operating room. So I think that we have technology available if your health system can afford it. I think you should be using the technology that you have. I'm a laparoscopic surgeon as well as you are, and we use laparoscopy as a second nature, and we don't think twice about using energy devices for laparoscopy. And I think energy devices is a very effective tool in especially either 4-gland or even localized parathyroid disease, because it allows you to make small incisions. It allows you to have a direct view of what you're doing, and you don't have to worry about ties coming off and these types of things. So I use a advanced energy device for all my cases. If I can, if the hospital I'm working at can't afford it, then I obviously won't use it. But if I can, and I also use a nerve monitor as much as I can. The reason why I use a nerve monitor is not so that I can kind of truffle find the nerve, which is what a lot of the surgeons in many different specialties, the argument they use to not using a nerve monitor, because it's almost like a bravado thing, like, oh, I don't need a nerve monitor to operate. I mean, I think that argument is, maybe 10 years ago. I think I use a nerve monitor. I know I use a nerve monitor because it helps because I do all my cases I do with learners. It helps learners understand the relationship of where they are to the nerve at all times. That's the first reason. And so I always, whenever I'm getting the learners to make a move, I always have them show me where they think the nerve is, and then where the dissection plane is going to be, and that actually helps them a lot in trying to understand how to do a safe move around the recurrent laryngeal nerve. Because as you know, that's the main difference between just plucking something out and somewhere else in the body and being in the neck. So I do use a nerve monitor, and the second reason why I use a nerve monitor is that it helps understand if we have any stretch in the nerve, and especially for when you're doing a total thyroidectomy or a four-gland exploration. You know that if you have any nerve signal problem on one side, you don't really want to go to the other side unless you've waited. Usually, you wait until you have a nerve signal come back, or that the vocal cord is moving. And that prevents any theoretically ever having a bilateral nerve injury, even temporarily, which sometimes requires tracheostomy. So those are the reasons why I use nerve monitor, and I try to use nerve monitor as much as I can. And so that's how I kind of set up with my technology to approach thyroids and parathyroids. In terms of the actual approach to the operation, I usually do a focused parathyroidectomy, even in patients that may have four-gland disease. At least I'll start off with it, and then I'll move to a four-gland exploration if needed. So I think that you have to have a good approach for your operation. But I try to standardize my operation. That's really key for, I think, all the endocrine surgeons I've ever worked with were very bent on standardization of their operation, and I think that takes out all the variables, because there's so many variables that can happen when you're doing functional surgery. That you try to minimize any of the variables that you can, and that gives you the best outcomes, I think, possible.
Can you now just walk us through a four-gland exploration, starting from the beginning and walking us all the way through it, and what are the steps and key maneuvers during the operation?
Sure. So I guess four-gland exploration, what you do is you make your incision in your neck. You'd make your subplatysmal flaps. You'd split the strap muscles in the midline. I know I'm digressing, but as a side note, I actually do a focused minimal invasive parathyroidectomy using a lateral approach sometimes. You wouldn't do that for a four-gland exploration. So in this situation, you split the strap muscles in the midline, and you start on one side. You pick a side, whatever you're more comfortable with. Or at least comfortable with. There was a surgeon that I worked with that always started on the right side, never started on the left, always started on the right. Even in thyroid cancer patients, he's doing a total thyroidectomy, he'd always, and the thyroid cancers on the left, he'd still start on the right, because he was more comfortable with the right. So I think you have your own, again, standardization. You have your own way of doing it. And then it started on one side. So let's say you started on the right. I usually try to find the inferior gland first, because that's what usually pops out first in the thyroid ligament. I'd inspect that and then see what it looked like. I'd then look to the right upper gland, again, medializing the thyroid gland away from the carotid artery, so you can see posterior to the thyroid gland. Again, you'd have to make sure the strap muscles were separated from the thyroid gland before you could do that, and then visualize the superior parathyroid gland. And I sometimes put a little clip on it, just so it's easy for me to find when I come back, because I plan to do a four-gland, so I'm going to come back to them. And then I'd go to the other side, take the strap muscles off the thyroid gland again, look at the inferior parathyroid gland the same way I looked at the other side, review it. Is it big? Is it small? Maybe put a clip on it, and then look at the superior parathyroid gland again, medializing the thyroid gland away from the carotid artery, away from the trachea, so you can see posterior to the thyroid gland, and review the parathyroid as well. I always find the recurrent laryngeal nerve as well, at least know where it's coursing. Again, it's going to course anterior to the superior parathyroid gland and posterior to the inferior parathyroid gland. And then I would put a clip on it. If I thought one of the big glands was on the other side, I would go back to the other side, take the big gland out. If I thought it was multi-gland disease, then I would take usually 3 glands out, maybe 3.5 if the last gland was quite big. But I would make sure that there was good vascularization to the remaining part of the gland. So if I was going to do a 3.5 gland exploration, 3.5 gland excision, I would do the half gland excision first, And then I would start taking the other glands out. And every gland I took out, I looked back to that first half gland excision to make sure it was still viable. Because if it wasn't viable, then it would just become another full excision gland. I almost never do a total parathyroidectomy and auto transplantation. I think that that's really not, it's not needed in most patients. And the problem with doing that is that they have 4 to 6 weeks waiting for that auto transplanted parathyroid gland to come back online. And when I say auto transplanting the parathyroid gland, we basically take that remaining parathyroid gland. We usually take 30 to 40 milligrams of parathyroid tissue, which is the normal size of a parathyroid gland, and we morcellate it and put it back into a highly vascularized muscle like the sternocleidomastoid into a pocket. I usually don't do that if at all possible, because if you took out all the parathyroid glands and just auto transplanted 40 milligrams of parathyroid tissue, you'd have a 4 to 6 week period of zero parathyroid tissue functioning until that auto transplanted gland started working. And in that period of time, patients are miserable, and it's dangerous. It's dangerous of patients because they either have profoundly low levels of calcium, or they get over supplemented and their calcium goes too high. So I think those patients are very, very high risk, and I try never to have that. The only patients that will sometimes have that situation are patients that have renal disease and they've had recurrence of their disease after already a subtotal parathyroidectomy. But in primary disease, I almost never try to have an auto transplanted parathyroid gland if at all possible.
I did want to just go back one more time to the tips and tricks for finding these glands, particularly if you're, a favorite Royal College question is about these ectopic versus supernumerary glands. So let's say if you're having trouble finding the gland, what are your sort of steps and maneuvers for trying to find a gland that may be in an ectopic position, and how do you differentiate between an ectopic versus a supernumerary gland?
So I think if you can't find a gland, first of all, for all surgeons that are starting in practice and wanting to do parathyroidism, that's awesome, and you can call me anytime if you have questions, or even intraoperatively. I've had my previous residents or even some colleagues call me, say I'm looking here, I can't find the parathyroid gland. I think it really just helps to have somebody around that knows the struggle, because even as a high volume parathyroid surgeon, I do hundreds of these parathyroid operations a year. I obviously still also have trouble finding parathyroid glands sometimes. And that's just because, as I said, the nature of development of parathyroid glands, they just don't always go in the same place every time. And so the as long as you have an algorithm in your mind of what you're going to do, you can stay calm and you can kind of get through the operation. And usually it'll pop up the place that you have in your mind to look. So let's just take the gland. So let's say you can't find the inferior parathyroid gland, and you've localized it actually to that area, and you've seen the other gland on that. Let's say you saw the superior parathyroid gland on that side, and it looks normal, and you're pretty confident this is a single gland disease and it's the inferior gland. So I think in that situation, you can think back to how this parathyroid gland is formed. And so the parathyroid gland comes, as I said, with the thymus. And so I would pull up the thymus. It's usually in the thymus. I've had parathyroid glands deep down in the thymus, and I pulled it up, and just it's not here. I'm pulling up, and right at the end, you have this big parathyroid gland pop out. So I've had that happen a few times. So in the thymus is a really key place to look. Another place is in the thyroid, especially if it's an inferior parathyroid gland. Sometimes you have these intrathyroidal parathyroids. The superior parathyroid gland can also be in the thyroid. So if you can't find one parathyroid gland and you found the other ones, especially if you did a 4-gland exploration, I would just take out that side of the thyroid. And I've had many parathyroid glands, up to 5% of parathyroid glands are in the thyroid. So I just take out the thyroid on that one side. Where else can you find the parathyroid glands? If you can't find the superior parathyroid gland, you can often look in the make sure you trace the recurrent nerve and the tracheoesophageal groove, because it's often hiding in there, or retroesophageal. Sometimes you can find them right behind the esophagus. And then they can also lie in the carotid sheath. I've pulled a couple out of the carotid sheath before. So I think that if you kind of really understand your neck anatomy and what the critical structure of the neck is, you could clear out the area and try to find the parathyroid, the quote unquote ectopic or supernumerary parathyroid glands in these abnormal locations fairly well. Sometimes you won't be able to find it, and that is something that we live with, and that is something that we can't control, especially if you're a high volume parathyroid surgeon. And the reason why that happens often is that it's deep down in the chest and you can't actually pull it up. And I go back to that story of Charles Martel, who had that multiple operations for parathyroid disease. It took, I think, I don't remember exactly, seven or eight parathyroid surgeries to find his parathyroid gland. And it was actually, they had to split his chest, and it was actually beside the pericardium. So parathyroid glands can be places that are not in the neck, and then you won't find it in a 4-gland exploration. And that's why these are very difficult surgeries sometimes, and sometimes very frustrating. So I think we need to be cognizant that there are non-traditional places for parathyroid glands. We have to have an algorithm what to do. Look at all the places, take out the thyroid on that side if needed, pull up the thymus, look behind the esophagus and around the tracheoesophageal groove, look at the carotid sheath. But as long as you're not causing harm and you're able to review those areas, and you can't find it still, then likely it's not in the neck, and then we'll have to close the patient up and figure out our next steps in terms of how to treat this patient.
The last question I wanted to ask you about parathyroid disease, and this has been a fantastic overview, is sort of defining what recurrent versus persistent disease is and how you approach both those issues.
So persistent disease is very clear. The calcium never drops, and that happens at a variable rate depending on the volume of the parathyroid surgeon, depending on what kind of surgery they did. Did they do a focused exploration? Did they a focused parathyroidectomy with no intraoperable PTH? Did they do a 4-gland exploration? Did the patient have familial disease? These are all kind of questions which give you, if you tell me this is what happened, I can give you a rate of a higher or lower risk of persistent disease. But persistent disease is when the calcium doesn't drop. Recurrent disease is when the calcium drops and then it kind of goes back high sometime in the future. And this happens very often in familial patients, specifically in MEN1 patients. And MEN1 patients, and I'll talk about that for a second because you talk about recurrent disease. This is a classic problem that we as endocrine surgeons face with MEN1 patients. And this illustrates the whole idea behind recurrent disease. So MEN1, as you know, is a disease of all the 4 parathyroid glands. And so what we try to do at the time of the operation is take out enough parathyroid tissue that their calcium will drop, and their calcium will drop for the longest possible time before it will recur, because the parathyroid glands are abnormal. And so even if you leave a little bit, they will become hyperplastic over time, and they will get worse and worse. Or they're already hyperplastic, but they'll get worsening hyperplasia over time, and they'll continue to increase the calcium level. And so what I try to talk to patients about is that you really want to do a parathyroid surgery on those patients at the last possible moment before they have complications from their parathyroid disease. And you want to do as minimal operation as possible, which will be as robust or as long, will help them as long-term as possible. And there's many different approaches now to MEN1 patients, but I think those patients, it's really important to factor in 2 things. Number 1, how long is it going to be before they need a reoperation? And number 2, what is the risk of the reoperation in terms of going into a scarred neck to try to find a small but overactive parathyroid gland? And that is something that the endocrine surgeon or any surgeon that's doing this operation should think of before they even do their first operation on this patient. And that's something that I think is another reason why we like to have algorithms, and we like to have a plan way ahead in advance for the second and third and fourth complicated operation that these patients are going to have.
I wanted to sort of close on one additional concept and approach, and Obviously it's the transoral methodology for thyroid surgery. To a lot of us that don't live in that world, it's mind blowing, quite honestly. So I'm curious, number one, if you could just describe for our audience that technique very broadly, and then secondarily maybe what the indications for it are, where it fits, and then I'm curious in particular. I know you've spent a lot of time thinking about the introduction of these new and sometimes quite radical introductions or technologies, I should say, into surgery.
Yeah, so I really appreciate the question. That's a big an area that I'm very passionate about. I mean, so first of all, transoral thyroidectomy, people even hear that and they say, what are you even thinking? Like, why would you even come close to thinking about something like that? Like, that is insane. To tell you the truth, I actually thought it was insane myself when I first heard about it during residency. And the first, basically, what it involves is taking the thyroid out through the mouth. And just as to put in perspective, there's been multiple different groups of surgeons around the world that have tried to do a minimally invasive approach to thyroid or parathyroid surgery without actually making an incision in the neck. And this comes from the whole idea of laparoscopy. So we used to make a big incision in the abdomen and we took whatever we had to take out. And then over the course of years, in the last kind of 20 years, we've started to say that we can actually do this with cameras. And I think it takes thinkers, outside the box thinkers, to try to understand that we can use our understanding of anatomy and tissue planes to try and approach the organs that we're taking out in a different way, which, number one, may obviate the need for a scar, but secondarily, in my opinion, more importantly, the view from a laparoscopic approach, as anyone that does any laparoscopic surgery knows, is way better in almost every circumstance than having an open approach, even if you're using loops. And so the whole idea behind this kind of surgical approach to thyroids and parathyroids started from thinkers like that. In addition, in East Asia, especially in Korea, there's a big stigma about having a neck incision, and so there was a lot of innovation on trying to do kind of remote access thyroid surgery there. They use the robot a lot as well in Korea, and they started something called the BABA approach, which was taking out the thyroid through incisions in the areolar area around in the breast and in the axilla. So they actually make incisions in the axilla and around the areola, and they actually tunnel under the platysma and take the thyroid out that way. And that has gained popularity and it's still going on quite extensively in Korea and East Asia. And then initially was actually Eastern Europeans, but then it was popularized and actually developed to what it is now by a surgeon in Thailand, in Bangkok, named Angkun Anuwang. And I went to go learn this operation from him. And he started this operation where you make small incisions just between the lip, where the lip meets the teeth, three laparoscopic ports, and you tunnel underneath the platysma, and you take the thyroid gland out that way. You actually have an amazing view of the thyroid. In fact, use a little bit of air. You can use a small suture to suture up the strap muscles, and you review the thyroid gland, and you can see the parathyroid glands exceptionally well. You can even use intraoperative ICG to view the parathyroid glands even easier. You can review the recurrent laryngeal nerve very easily. You can use a nerve monitor as well in the laparoscopic approach. So I think all the his operations done flawlessly. I went to go, as I said, learn from him, and it's his approach, his protocol, his outcomes are really amazing. They're the same. They're basically, his outcomes are the same as most high volume surgeons have through the center of the neck. So I think the approach is feasible. It's safe. It's effective, and even for teaching purposes, it's actually way better. For any of you that have been like the second or third assist in a thyroid surgery, you're not seeing really anything. You have multiple heads in there, and you can't really see what's going on. It's the same like when I was a resident, and I was the St. Mark's guy in a rectal case. You're not seeing anything. And when laparoscopic rectal surgery came along, I started being able to visualize everything. So I think it's a similar kind of idea, and it's really an amazing view that you have. I think it really comes with people that are passionate about innovation. And you're going to have early adopters, as you know, for any type of new technology or new approach. And then it's going to take some time for the early adopters to popularize it. And then once it's popularized, then you have to start teaching people how to do it in the masses. And that's something that I'm trying to do. We started a new fellowship program in endocrine surgery in Toronto. So, and I'm doing transoral thyroidectomy. So hopefully the endocrine surgical fellow will take those skills to wherever they practice. And I think that's kind of the idea of trying to train the next generation in the new technology. And you're still going to have people that say, that's insane. How could you ever think about that? But you have the same people saying that for laparoscopic cholecystectomy. So that doesn't deter me at all.
You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. If you've liked what you've been listening to, please leave us a review on iTunes. We'd love to hear your comments and feedback, so feel free to email us at podcast.cjs@gmail.com or connect with us on Twitter @CanJSurge. Thanks again.